Good morning to all panelists, speaker, and all the National Glaucoma Meeting 2021 participants. Welcome to the rapid fire session. My name is Zera Seka Jamal. As your host for this session, I would like to thank Professor Paul Healy, Dr. Firna Dwi Oktariana, and Dr. Imade Agus Kusumajaya to be able to attend to this session as our panelists. In this rapid fire session, each speaker will present their topic in 7 minutes time through pre-recorded video, after which the panelists will give their thoughts and comments regarding the topic. Each panelist will have 1 minute to convey their opinion. Due to the nature of this session, the discussion is intentionally made brief. The presentation is chosen, hopefully will trigger an interest regarding the topic or act as a reminder. We will start the first presentation by Dr. Raine Nathalie Christine with the title, The Coincidence of Glaucoma and Cataract Surgery in Pregnancy, a Case Report.
Good morning to all participants of the National Glaucoma Meeting. My name is Raine Nathalie Christine, and I would present a case report with the title, The Coincidence of Glaucoma and Cataract in Pregnancy. This is a case presentation of 26-year-old pregnant woman with the blurred vision on both eyes since a week ago with pain on the right eye. 5 months before the admission, patient felt pain, blurred vision, and redness on right eye, and she treated herself with the steroid eye drop. 3 months before, she felt redness and blurred vision on both eyes, prominently on right eye, and she knew that she got pregnant. 1 week before, the blurred vision getting worse, especially on right eyes, and pain. There were no history of past illness and no history of glaucoma disease in family. From the general examination, vital sign within normal limit, and ultrasonography examination revealed a 16-week-old healthy fetus. This is the examination of right eye. The visual acuity was hand movement with the redness on conjunctiva, the cornea mild edema, and the pupil mild dilated with the subcapsular posterior opacity on lens. From fundoscopy examination, I found a pale optic with CD ratio 1.0, and this is a schematic optic disc diagram. The intraocular pressure was 48 millimeter mercury. This is the gonioscopy examination of the right eye. I found a scleral spur in 4 quadrants. This is the left eye examination. The visual acuity was 0.4 with no improvement with pinhole, and the redness on conjunctiva, the pupil mild dilated with subcapsular posterior opacity lens. CD ratio was 0.7 with cupping, nasalization, and bayonet sign. The IOP was 40 millimeter mercury. From the gonioscopy examination, I found scalar spur in 4 quadrants, and the visual field examination revealed a pinhole vision on the left eye. The working diagnosis of this patient are right and left eye steroid-induced glaucoma, right and left eye subcapsular posterior cataract in 16 weeks pregnancy woman. There were several problems in this case. First, there was limited choice of therapy in the pregnancy on the glaucoma patients, and the trabeculectomy surgery in pregnancy needs several considerations. As a management, I plan to do this 2-step surgery procedure, which is trabeculectomy first, then phacoemulsification. I did the collaboration with obstetrician to prepare the surgery, and patient treated with brinzolamide eye drop twice a day. The trabeculectomy on the left eye was performed first under subtenant anesthesia, and we did the paracentesis intraoperative. The pre-surgery intraocular pressure was 42 millimeter mercury. From the follow-up of the left eye, we found after the 30 days of the trabeculectomy done, the visual acuity has improved from 0.3 to 1.0 with spectacles correction, and the IOP was 12 millimeter mercury. Bleb was performed with deep anterior chamber. And I performed the trabeculectomy on the right eye 2 weeks after the left eye. Trabeculectomy was performed under subtenant anesthesia. The pre-surgery intraocular pressure was 45 millimeter mercury. And from the follow-up of the right eye, we found that on the 30 days after the trabeculectomy, the visual acuity still hand movement with cloudy lens, the black was formed with deep interior chamber, and the intraocular pressure was 18 millimeter mercury. The patient treated with brinzolamide twice a day after the surgery on right and left eye, polydimycin dexamethasone eye drop, mefenamic acid if needed, and we plan to do the phacoemulsification 3 months after delivery. As the discussion, to date, there has not been a fixed guideline on the management of glaucoma in pregnancy. In this case, monotherapy with topical brinzolamide followed by the surgery to manage the progression of glaucoma. The surgery went smoothly and target IOP was achieved. And this is an example of recommendation from the latest journal that suggests alpha agonist as the first-line medication for anti-glaucoma during the pregnancy for the first trimester and second trimester. And this treatment was given based on the FDR recommendation based on the adverse effect of glaucoma medication during pregnancy and breastfeeding. And what if there is no alpha agonist topical in remote areas? Timolol can be used as the first-line medication with certain risks, and that's why we have to still observe the condition of the patient and the fetus collaboration with the obstetrician. And glaucoma surgery in pregnancy, when we have to do it. Failure of conservative management combined with the disease progression makes surgical intervention inevitable. Laser trabeculeplasty could be considered. And there were several considerations of glaucoma surgery in pregnancy based on this journal. First, the surgical option could be the filtration surgery and MIGS. And we should choose the local anesthesia, lidocaine and etidocaine. Position of the patient during the surgery because the gravis teres can cause the hypotension intraoperative. And we should avoid the mitomycin C and 5-fluorouracil because it's FDA category X. And that's all for my presentation. Thank you.
Thank you, Dr. Reina. So I will start with Professor Paul Healy. Good afternoon, Prof. I believe it's 2 o'clock in Australia. Do you have any comments regarding the case?
Yes, thank you. This is clearly a difficult case which has been handled very well. And I think the description of the dilemma of treating pregnant patients with high intraocular pressures is certainly accurate and reflects, general written advice. I think from a practical point of view, of course, we all know that medicine is always a matter of risk and balances. And those relative contraindications that were presented for medical therapy for lowering intraocular pressure are valid, but the risk is actually low. So, for example, I did see on the slide a note that animal studies showed high incidences of miscarriages, prostaglandins. That's not actually correct for a prostaglandin eye drop. It is for intravenously or maximally dosed prostaglandins. So, as with any decision, we really need to weigh up the risks and benefits. When I did my fellowship at Moorfields, we had a large number of young adults who were still on low-dose Diamox, many of whom got pregnant. As far as I know, the hospital didn't see a single birth defect, and that really is the drug that has the highest teratogenic risk. In this situation, however, it's advanced disease, and a trabeculectomy is absolutely the right way to go. I commend the handling of the case.
Thank you, Prof. Dr. Virna, since there's also a cataract in this case, do you have an opinion regarding the timing for the surgery?
I agree with the presenter that we don't need to perform the cataract as soon as possible, because we know this is the very advanced case glaucoma, and then also the patient is still in pregnancy, so we could wait until the filtration is well enough. The wound modulation has been well formed, then we could do that afterward. I usually do the cataract surgery if I did the filtration surgery, at least I wait until 4 months to 6 months. Then I will do the cataract surgery.
Thank you, Dr. Firna. Dr. Agus, any additional comment?
Yeah, thank you, Dr. Sarah. This patient, use steroid a long time, maybe, become pressure is high, and there was subcapsular cataract. I agree for the suggest for the Dr. Paul, Paul and Dr. Firna. I first surgery by trabeculectomy first, and then a phaco cataract. This patient. Thank you.
Okay, thank you, Dr. Agus. Okay, so it concludes the first presentation. We will now move on to the second video. Thank you, Dr. Reiner. We will start the second video by Dr. Maya E. Suwandono with the title of Neovascular Glaucoma, Be Patient.
Hello, a very good day to everyone. My name is Maya Suwandono, and first of all, I would like to thank the 8th National Glaucoma Meeting organizers for letting me be a part of this rapid fire session. This case of mine is a male, 71-year-old patient that had a history of the left eye with ZRVO and CME. And actually, this patient was referred to me by one of our vitreoretina surgeons due to persistent high intraocular pressures after vitrectomy and intralimited membrane peeling because there was epiretinal membrane. And from the macular OCT, we could find that the vitrectomy was done successfully. From the findings, we found that the left eye had a visual acuity of hand movement, and the intraocular pressure was 34 despite of maximum glaucoma therapy. And gonioscopy, we found that there was neovascular in almost 360 degrees, and there was a Cupples ratio of 0.8 with a thinning of the RNFL in the superior and also inferior part and really bad visual fields. So this case is a neovascular glaucoma that is known to be very difficult to be managed and resulting in very tragic visual loss, but is very closely related to retinal ischemic diseases. And CRVO, especially the ischemic ones, are found to be more risky in developing neovascular glaucoma. So after discussing with the patient, so we decided to put in a glaucoma drainage device. In this case, we put in Ahmed tube glaucoma valve glaucoma device that was found to be very effective and also safe as a treatment for neovascular glaucoma. And recent studies has also encouraged to the use of Ahmed glaucoma devices as the primary surgery in refractory glaucoma. However, when we did the preparations for the surgery, we found that this patient had very low cell endothelial counts. So our next plan was to insert the tube through the sulcus so we could reduce further corneal endothelial decompensations. So that was what we did. And the surgery itself went very well. We could insert the plate and also fixated the tubes. And in our second attempt in inserting the tube under the iris or through the sulcus, we did succeed in its second attempt. But the tube could be placed really nicely above the IOL. So we covered the tube with the scleral graft and also covered the scleral graft with the conjunctiva. On day one, actually, I was quite delighted with the surgery because we didn't see any hemorrhages, and also the tube could be put nicely, and we could actually see at the end of the surgery, it was just piping out a bit from the edge of the pupils. But on the first day, when the patient came back, the pressure was still quite high. It was 38, and we found a massive blood clot that was covering the whole tube. So looking at this, I went directly into the operating room again and tried to aspirate and also tried to open up the opening of the tube as much as I could. The blood clot was quite tough already, and once we succeeded to open the opening of the tube, we could see that there was still active hemorrhages coming out. So I inserted some viscoelastic to try to stop the hemorrhages. So on day 5, the patient came back and the pressure was 33. And I was devastated because it seemed like what I tried to do on the first day post-op, trying to open up the tube, was nothing. Nothing had been done. So the tube was still closed with the blood clot. But on day 15, which was the second week of the operation, the IOP started to go down. And I was very surprised and also happy to see the tube. I could start to see the opening of the tube. And the patient was also relieved and also starting to feel that there was hope. And on the third week post-op, the pressure was good. And ta-da! We could see the tube clearly and there was no blood clot at all. So from this case, we could learn that actually severe hyphema could result in IOP elevation post-operatively, and tube obstructions post-operatively is about 5 to 11%. And anti-VEGF injections could reduce the post-operative bleeding risk, but complete tube obstructions by blood clot after the surgery is still something that is very unpredictable. We should always try to remember to do a management conservatively first with steroids orally and also topical before we go in and do any surgical procedures, because we do have to go back to the operating room and it may precipitate new bleeding. There's a new study that found that intracameral air injection may prevent the tube obstruction by blood clot. So from this case, I learned to be very patient and try to sit back and see what happens first. Okay, thank you very much.
Excellent presentation, Dr. Maya. So maybe this time we'll start with Dr. Firna. Do you have any comment regarding the timing to go back to the operating room? We wait on when will we do the intervention if necessary?
Thank you, Dr. Zerais. Actually, if I have a case like this, I will wait, because we know that in neovascular glaucoma, we have a very high risk of bleeding. So we will wait and we will give the oral and topical glaucoma medication first, and then also anti-inflammation, just as Dr. Maya has learned from this case. We will wait maybe for about several weeks. Usually in 2 weeks, in 2 or 3 weeks, this bleeding will resolve itself. We have learned that a lot from the patient with the neovascular glaucoma. So just be patient. Yeah, just be patient and we will see.
Thank you. Dr. Agus, any comments?
Yeah, thank you. Dr. Maya is a very good job. Yeah, usually the common complication of the neovascular glaucoma is hemorrhage, the bleeding, because most of neovascular for the iris and angle, very chilling for me. Yeah, usually very common for the complication is glaucoma tube, glaucoma drainage device. But Dr. Maya is a good job, yeah, good, very good, excellent.
Thank you, Dr. Agus. And Professor Falhili, what do you think about using laser NDR to open up the clot? Any comments?
Look, I think it works a little better for fibrin, and when there's less sort of about. When you have a clot that size, essentially you're just going to be moving the clot around, because as we know, the clot is very rubbery and elastic. So I don't think, I think it was perfectly reasonable to go in again. I guess the main lesson of this common problem is, how we go about trying to minimize the bleeding. What I've found to be most effective is intravitreal Avastin. That should be when your, retina chap rings you up and says, I've got this patient, your first question is, has he had the Avastin? Yes. That obviously causes vasoconstriction and some regression of the new vessels. The second issue, of course, when you're inserting, going through the sulcus is a great idea, but you need to have good visibility. And so doing a blind pass, you're much more likely to hit those blood vessels. There is a mechanical type technique which works very well. What I'd always recommend is, particularly when you've got an eye with poor vision, make your tube very long. When I put these tubes in, I have the tube sitting almost in the center of the pupil. The patient won't notice it, but if it's sitting that far and the bleeding comes from the insertion site, gravity tends to make the blood sit down the bottom, so you've got less likelihood of actually getting an obstruction. But, well handled, common situation.
Thank you, Prof. Thank you, Dr. Maya. We'll move on to the next presentation. Our third presentation by Dr. Vidya Anandita with the title, The Dreadful Fate of Acute Glaucoma, Why LPI Should Not Be the Endpoint.
Good afternoon to all panelists and participants. Thank you for giving me this opportunity. Today, I'm going to talk about the dreadful fate of acute glaucoma, why LPI should not be the endpoint. Acute glaucoma can happen to up to 15.5 people per 100,000 population, depend on ethnicity. And what is scary about it is 17.8% of this patient then went blind in 4 to 10 years. Prognosis is based on duration of attack, IOP at presentation, and ethnicity, and this is where we in Indonesia fell short. Our data from Cipto Gangunkusumo General Hospital shows that the median of onset to presentation is 5 days, which is very long for acute glaucoma. The range goes to 1 to 60 days, even longer. LPI is generally accepted as endpoint of acute glaucoma attack, and that is what I'm going to talk about today. This is a case of Mrs. S, 59 years old. She had sudden blurry vision of right eye since 6 days before admission with pain, headache, and halos. She was already blind in left eye since 2 years before admission following another acute glaucoma attack. The visual acuity on her right eye was hand movement, and on her left eye was no light perception. The IOP on right eye was 75.6, and the right eye was hyperemic with corneal edema, very shallow chamber, mid-dilated pupil with no light reflex, and a hazy lens with glaucoma flecken. So we did LPI with sequential laser, initial area of the right eye, and gave maximum medication, and the patient was controlled in 1 week. After 1 week, visual acuity was 20/80. The IOP was dropped to 13.9 with a now clear cornea and deeper anterior chamber, and we can see a pattern iridotomy. Patient was advised to undergo phacoemulsification in right eye, but refused due to financial reasons and then lost to follow-up. 2 months later, we met the patient again, but now the visual acuity has dropped to 20/200 with IOP of 74.5. The cornea was edematous with a very shallow and anterior chamber, and now the pupil was mid-dilated but with macrobiosis on superior, and the iridotomy was already closed. Patient was advised to undergo GDD implantation but still refused due to financial reason. So we gave the patient maximum medication and then asked to come back in 1 week. The week after, the visual acuity was hand movement. The IOP has actually dropped to 57.5, and thus we can see the optic nerve head, and the CD ratio was already 0.9 with mark cupping. And finally, we were able to put the patient into our financial aid scheme, and the patient underwent VGI the next day. Unfortunately, it was very hard to gain early IOP control on this patient. The patient was still on maximum medication until 7 weeks following the VGI, after flushing of G tube, and afterwards we can control her IOP lower than 20 with only topical anti-glaucoma medication, but the visual acuity remains hand movement. So what went wrong in this patient? What to do in acute glaucoma? Well, first priority is to break the attack. The conventional management is IOP control medically, and then followed by LPI. If the cornea was still edematous, then we have option to do corneal indentation or laser peripheral iridoplasty or paracentesis. And when the cornea clears, we can then do LPI or phacoemulsification. If the cornea is still edematous, then we can opt for surgical PI. But the problem with LPI in Asian patients are that the success rate for LPI in Asian patients are generally lower than Caucasian eye. It is 41.8% compared to 65 to 76% in Caucasian eye. Why LPI failed in Asian patient? Well, Asian seems to have more severe attack compared to Caucasian with longer duration of symptoms, and therefore had worse angle damage with more marked PAS. And when we do LPI in Asian eye with dark brown iridis, we need more laser energy which in turn then cause more inflammation and pigment dispersion, and this then cause worse trabecular damage. Asian also have genetic and anatomic predisposition to progress to PACG, and therefore it is very important to prevent recurrence of acute attack and progression to PACG in patient with acute glaucoma in Asian eyes. So how do we do that? One of the options that we have is to do phacoemulsification. We can do it as a primary intervention, or it can also be done following LPI. Both can lower IOP and number of medication. Early phacoemulsification in APAC also shows good result. Here we can see that in the phaco group, there's no complete failure, and it has a higher complete success compared to LPI. And in the study by Lam et al., we can also see in this Kaplan-Meier graph that the phaco group has significantly better survival. But the problem with early phaco is that it came with its own set of challenges, such as shallow AC, dilated atonic pupil, zonular weakness, and low endothelial count. So it has to be done by a very skillful and experienced surgeon. The other problem with our population also that sometimes most of our patients came in late, so a lot of them we fail to control it medically, and therefore another option is to do trabeculectomy. It can also be done in patient who has medical success but have signs of chronic angle closure glaucoma. Sadly, the success rate is not as good as when we do it in quiet eye. It is only 56.2% in 1 year, but we still perform it a lot, as patients tend to have in our practice in Indonesia tend to come in late and have failure to control IOP medically. The success rate of trabeculectomy in APAC in Cipta Mangunkusumo General Hospital is better. It is 66.7% in 6 months. So it is an option. So what are the factors contributing to the development of PACG in APAC patients? Again, the most important factors are the mean duration of symptoms before presentation and the mean duration of time taken to break acute attack. So it is very important for us to keep educating our patient to come in as soon as they feel like they are getting glaucoma attack. So the take-home message for my presentation: first, it is very important to prevent recurrence of acute attack and progression to PACG in post-acute patient. Patients such as mine with worse access to healthcare, we should probably opt for more aggressive approach to ensure longer and better control in long term. Early phacoemulsification in APGS shows promising result, but may not be applicable in a lot of our population, and therefore public education is to be encouraged to shorten the duration of from attack to presentation. Okay, that's all for me. Thank you for listening.
Thank you, Dr. Widya. Dr. Agus, any comment regarding this case? Dr. Agus?
Unmute, Dr. Agus.
Can you unmute first, Dr. Agus? Okay. Maybe perhaps we move on to Professor Paul Healy first. Do you have any opinion regarding the choice of surgery, Professor Paul Healy?
Look, I think there are two important lessons from this case. The first is that while the descriptions of the treatment of acute angle closure are correct, they're not accurate. They don't reflect current knowledge. You know, when we talk about a PI being a treatment for angle closure, that's like saying timolol is a treatment for open angle glaucoma. Sometimes it's a PI, sometimes it's something else. PI is a treatment for pupil block. And the reason that Asian patients have more problems with angle closure is they have more non-pupil block mechanisms. And if you look at the results of the EAGLE study, which was the early lens extraction study for angle closure, in my opinion, one of the main reasons they found a slightly higher success rate for the lens extraction group was actually because about a third of the patients were from China. So I wouldn't discount the lens extraction for angle closure because of the difference anatomically and physiologically between Asian eyes and European eyes. All the arguments for lens extraction are actually much stronger in Asian eyes because of the non-pupil block mechanisms. The second lesson, of course, is how we make our health system work so that we have the privilege of treating patients on clinical need, not an ability to pay. And all countries face that problem. In most countries, there is public funding for emergency treatment and emergency surgery. And so really the lesson here is that sometimes a cataract extraction can be an emergency procedure. And we need to let our health administrators know that, so that this person could have had the appropriate surgery done when she first presented, rather than suffering the tragedy of a loss of vision through clinically unnecessary circumstances.
Thank you, Prof. Maybe Dr. Agus, just a quick comment.
Yeah. Thank you. Sorry,
because out of time. Quick comment. Yes.
Yeah. This patient is very difficult. Yeah. Maybe both eye, primary angle closure glaucoma, and maybe before there chronic primary angle closure glaucoma, and left eye is blind eye, and right eye is acute attack. I think my opinion, the first management is initial treatment by medical treatment, and we look the gonioscopy or how many peripheral anterior synechia, what is white, I think direct to trabeculectomy and then PICU. If there was little bit posterior anterior synechia, maybe is LPE, is good, but and continue the monitor on the IOP, it's low, direct the PICU emulsification, but very challenging for the PICU.
Yeah. Thank you, Dr. Agus. Due to limited time, we may have to move on to the next video. Next is Dr. Sony Umbara with the title Neovascular Glaucoma in Poor Vision PDR Patient. What is the best management option?
Good morning. Assalamualaikum warahmatullahi wabarakatuh. I would like to thank the 8th National Glaucoma Meeting Committee and Indonesian Glaucoma Society for this opportunity. Today, I will present a case report entitled Neovascular Glaucoma in Poor Vision PDR patient. What is the best management option? Neovascular glaucoma is a devastating ocular disease causing irreversible vision loss, 1/3 or caused by diabetic retinopathy. Treatment aims to treat the underlying pathology and to control the IOP. We have a 61-year-old male patient with chief complaint of decreased vision in both eyes. The patient had been experiencing gradually decreased vision in the right eye since 2 years. There was redness, there was no pain. The patient had a history of diabetes mellitus for 20 years and the history of cataract surgery 2 years ago. Patient was diagnosed with PDR with history of unretinal photocoagulation 2 times for the right eye, 1 time for the left eye, and history of anti-VEGF injection 7 times of the left eye. Patient was referred by a previous hospital because of high IOP and responsive to medical therapy. The visual acuity was hand motion for the right eye and 3/60 for the left eye. The IOP was 52 millimeter mercury. The patient had slight corneal edema. The anterior chamber was conheric grade 3. There was neovascularization of the iris, PCO, and the CD ratio was 0.7. On the left eye, the IOP was 16 millimeter mercury. It was slightly oval pupil. There was PCO, and CD ratio was 0.5. Conoscopic examination using Sussman 4 mirror. The angle was close in all quadrants, and there was extensive neovascularization of the angle. The left eye, the angle was open. The media was hazy, but we can see in this photograph the enlarged CD ratio of the right eye and normal CD ratio of the left eye. We did a B-scan ultrasonography, and there was tractional retinal detachment of the right eye. We didn't get a good quality of OCT. The signal strength was 2 and 4, but in the macular OCT, we can see tractional retinal detachment of the right eye and macular edema of the left eye. The endothelial cell count was low for both eyes. We diagnosed this patient with neovascular glaucoma of the right eye, PDR, pseudophakia, diabetes mellitus, and stage 2 hypertension. We consulted the patient to the vitreoretinal unit, but there is no plan for vitrectomy or anti-VEGF injection. The patient was planned to be given additional PRP after the IOP is controlled. We planned the patient for GDD implantation of the right eye under general anesthesia. In the meanwhile, we gave the patient timolol and acetazolamide. Preoperative, the IOP was 38 millimeter mercury. We gave the patient intravenous mannitol, and the IOP decreased into 28 millimeter mercury. During the operation, we made conjunctival peritomy and the supratemporal area. We implant the Berfeld glaucoma implant. We secure the plate 8 millimeter from the limbus using 6-O-proline, and we ligate the tube tightly using 8-O-Vicryl. And we trim the tube. We plan to insert the tube far away from the endothelium. So we inserted the tube into the sulcus. But we want to be able to evaluate the tube after the surgery. So we made peripheral iridectomy first. The OVD was injected. The tube was inserted and fixated using 10-O nylon. 2 fenestrations were made, and the tube was covered by scleral patch graft. The OVD was irrigated, was aspirated, and all these incisions were sutured. The tenon and conjunctiva were closed layer by layer. 1 day after surgery, the visual acuity was hand motion. The IOP was 28 millimeter mercury. The AC was formed with coagulum and air bubble. The tube was visible, and we continued the medications. 1 week after the surgery, there was an improvement of the visual acuity, and the IOP was 22 millimeter mercury. And there was slight or a small amount of coagulum in the anterior chamber. As a discussion, NVG management is challenging and very difficult. The principle of the management of the NVG is of two. First, treat the underlying pathology, and the second, control the IOP. This patient, the patient had diabetes mellitus, and ischemic retina should be treated using PRP and anti-VEGF, or vitrectomy if needed. Control the IOP medication is effective only in open-angle stage. Trabeculectomy with anti-metabolite can be considered in quiet, non-inflamed eye, but has high failure rate. The aqueous tube shunt has better success rate than trabeculectomy, and the loss of vision rate is lower than cyclophotocoagulation. But in the patient with no useful vision, or if all else is contraindicated or fails, we can choose cyclophotocoagulation as the treatment of choice. These were my references. Thank you for your attention.
Thank you, Dr. Shani. Back to you, Professor Paul Healy. Any comments?
This has many characteristics of the CRVO case. Of course, with diabetes, the problem is doubled because this is a bilateral disease usually, whereas bilateral CRVOs are quite rare. So I think the management was absolutely appropriate. I think probably the message is, no matter how bad things look, you've got a tractional detachment, you've got terrible macular edema, which has caused all sorts of damage to the outer retina, but you don't give up because this might end up being the better eye. I'd make the same points I made last time. Long tubes, even when your vision's reasonable, tubes don't cause vision disturbance. And a PI is a way certainly to observe the periphery of the tube, but yeah, just make it long. And the stenting, the Sherwood slits, all those things are required. And I think really pragmatically, if you can settle an eye down with the Avastin and the PRP, you can get great results from a mitomycin trabeculectomy because it's a low output state. But from practical perspectives in Indonesia, if I was there today, looking at that patient, I'll be putting a GDD in as well.
Thank you, Prof. Dr. Firna, any comments?
Yes, I think I only brief that be very careful if you want to perform the iridectomy in the neovascular glaucoma. It could cause like a bleeding, only that. And I agree that we could put a longer tube to evaluate the tube under the iris. Thank you.
Okay, thank you. And Dr. Agus, last comment?
Maybe for the long follow-up, look for the ischemia retina, maybe for the by pan retina photocoagulation continue and anti-APGS because the result for the IOP by GDD only maybe 1 year and then come elevated. Thank you.
Thank you, Dr. Agus.
Unmute, Dr. Zeras.
Yes. Okay, thank you, Dr. Firna. So up next is Dr. Anissa Wicaksono, iridocorneal endothelial syndrome, diagnosis challenges.
Good morning, professors and doctors. Today I'd like to present for this rapid fire session, a case of iridocorneal endothelial syndrome diagnosis challenges. Our patient was female, 50 years old, with a chief complaint of blurred vision since 6 months before admission. At 2 years before admission, the patient went for an eye checkup and was told that there was irregularity in her eyes, although at the time there is no subjective complaints. 9 months prior to admission, the patient felt continuous discomfort on her left eye. And then she went to an ophthalmologist and was told that she had her eye pressure increased. Then she was given eye drops medication. Patient then felt blurred vision starting 6 months before admission, and then 2 weeks before admission, the patient was told that she has multiple pupils and referred to our hospital. At the time of admission, the patient denied any previous eye redness as well as any episodes of halos. From the examination, we found a 6/6 visual acuity of the right eye with correction. The IOP was 12 using applanation, and the anterior and other posterior segment were within normal limits. While for the left eye, we found the visual acuity was 6/18 with correction. The IOP using eye care was 34 millimeter mercury. We found edema on the cornea, haziness, and also shallow angle in the temporal and nasal of the anterior chamber, but there is still a grade 2 to 3 von Herrick on the central area. The iris and pupil were irregular. We also found correctopia as well as polychoria, and there is anterior synechia on nasal and superotemporal region. There's slight grade 2 haziness on the lens, while the fundus we found round optic nerve head with still distinct edge and the cup-piece ratio around 0.4 to 0.5. Unfortunately, we could not perform gonioscopy on the left eye due to the corneal edema, but we still found open angle grade 4 on the right eye. From the Humphrey automated perimetry, it was shown very early defects on the left eye, but the MD was still above -6. From the OCT, found a larger cup-piece ratio of the left eye, around 0.6 to 0.7, but the RNFL was still within normal limits. However, this OCT result might be slightly unreliable, as we can see from the signal strength is still not ideal. We therefore diagnosed the patient with secondary glaucoma of the left eye due to suspicious iridocorneal endothelial syndrome, progressive iris atrophy type, or Chandler syndrome type, as well as complicated cataract of the left eye. We plan to perform anterior segment OCT. However, due to emerging COVID case, the patient refused to come back to the hospital, but we already gave anti-glaucomatous medication, consists of timolol 0.5%, latanoprost eye drop, and a combination of benzolamide and brimonidine eye drop 3 times. And we also plan to perform trabeculectomy with mitomycin C or Ahmed implant to the left eye. The diagnosis of eye syndrome generally was marked by the clinical features. There are 3 types, although determining which type the patient is won't affect the treatment of choice, but it will suggest the long-term prognosis of the condition. In our patient, the clinical features were corneal edema, polychoria, and also correctopia. Therefore, we're still unsure of which type she is included, either the Chandler syndrome or the progressive or essential iris atrophy. From literature, it was stated that the most common type is the Chandler syndrome, counting around 50% of all eye syndrome cases. There are several differential diagnoses that we may need to consider when we encounter such clinical findings. I'll try to sum it up in this table, but the distinguished feature that we found in our patient is she was having the condition in an adult age, and also it was found unilaterally, while the other diagnoses, the similar clinical features tend to found in younger age and also occur bilaterally. In our patient, gonioscopy could not be performed due to the edema of the cornea. Therefore, having anterior structure assessment using anterior segment OCT or ultrasound biomicroscopy is essential to detect the changes in anterior chamber angle structure and also the peripheral anterior synechia. Though the definite diagnosis is still need to be made through spectrum microscopic examination. Some literature suggests IVCM or in vivo confocal corneal microscopy because it has superior feature of still able to show the endothelial morphology even with the haziness of the cornea condition. We need to find the pathognomonic feature, which is the eye cells. For the therapy or management for eye syndrome is focused on maintaining the intraocular pressure as well as trying to reduce the corneal edema. We can choose from medical therapy, either using IOP lowering agent, preferably aqueous suppressants such as beta blocker, alpha adrenergic agonist, and also carbonic anhydrase inhibitor. And also we can use hypertonic saline eye drops to reduce the corneal edema. The options for surgical therapy is for the glaucoma condition is either trabeculectomy with mitomycin C or glaucoma drainage device. Both has an initial success rate around 70%, but at 5 years, GDD found to be more favorable with a 50% chance of survival. In a severe decompensated cornea cases, we could consider keratoplasty, although the rejection and failure rate is knowingly high. The diagnosis of eye syndrome, although sometimes clinically straightforward, but the definite diagnosis will need specific ancillary tests. And the main goal for therapy is to control the IAP in order to reduce the risk of glaucomatous damage and also prevent further damage to the cornea. And so therefore we could preserve the visual function. Education to the patients regarding the prognosis should be stated early, as not only the disease may be progressing, but long-term follow-up and repeated surgeries is possible. These are my references. Thank you for your kind attention.
Thank you. Dr. Firna, any comment regarding the diagnosis of this case?
Thank you, Dr. Zeras. Yeah, actually, we still need other diagnosis, especially for the corneal condition. Usually, if we could do the pachymetry examination, we could see how is the condition of the endothelial cells. Although we still have to, I don't know, this patient only one eye, right? Only one eye with the corneal edema and also with the iris condition like polychoria and correctopia. It is highly possible that this is a ICE syndrome, but still, if we want to know whether there is a corneal problem, we have to perform the pachymetry examination. I agree with Dr. Anissa with this.
Okay, thank you, Dr. Firna. Dr. Agus, any comment?
Yeah, I think this patient is eye syndrome because causes 3 variant, yeah, 2 variant, maybe Chandler syndrome, maybe, yeah, Chandler syndrome, because it's common, the Chandler syndrome. They're very difficult this to mention because it's a problem. There are endothelial cornea, and this is which I popularly block glaucoma. But maybe the keratoplasty is for the good endothelial cornea. Jadi,
thank you, Dr. Agus.
Yeah, thank you.
Professor Paul Healy, any comment regarding the management for this case?
I think the management really comes down to how aggressive those endothelial cells are. And I know, we give this disease different names like Chandler syndrome and Cogan-Reese and progressive iris atrophy. It's all the same disease. If it's mild, we call it Cogan-Reese, but there are many presentations of eye syndrome much more mild than that. And the most important thing in that situation is to think of it. So, beware the unilateral high eye pressure with a funny looking cornea, or even without a funny looking cornea. I agree completely with Dr. Verma that the cornea is the key. And even in an eye which is otherwise looking normal, but has it's just raises your clinical suspicion, specular microscopy can often help you make the diagnosis. In terms of treatment, again, it depends on the aggressivity. I've looked after patients with a very mild form of the disease who have done extremely well from trabeculectomy. In a very aggressive form, we think that we've got less chance of those endothelial cells migrating up a tube than they have migrating into a sclerostomy. So we tend to prefer a tube. It's very difficult though, because hopefully, no matter what you do, this will always be the worst eye of the patient. And patients need to be educated for that. The main reason we're doing it is so that we don't end up with an eye with no perception of light, which is the ultimate fate.
Okay, thank you, Professor Papili. Thank you, Dr. Anissa.
Thank you, Prof. Thank you, doctors.
Okay, next, the next speaker is Dr. Nur Khaironika with the title of Traumatic Subluxated Mydriatic Cataract and Secondary Angle Closure Glaucoma.
Good afternoon, everyone. Thank you for the opportunity to share my case today. A 65-year-old female came to our hospital on 20th of October 2020 with the chief complaints blurring of left eye vision since 2 months before coming to the hospital, history of injury to the left eye, history of local ophthalmic consultation, and the patient was planned for surgery but then cancelled several times. Ocular examination on the left eye showed a visual acuity of 20/400, stromal edema on the cornea, AC was shallow, atrophic patches on the iris, mydriasis and non-reacting pupil, and a subluxated hazy lens with zonulisis more than 180 degrees. IOP examination on the left eye was 54 millimeters of mercury. Gonioscopic examination on the right eye was open angle. The left eye was occludable and not opening with indentation. Diagnosis of the left eye was pterygium and traumatic subluxated cataract with secondary angle closure glaucoma and a traumatic mydriasis. We gave the patient IV mannitol and medical therapy with anti-glaucoma medications before taking the patient for surgery on the next day. This video of phacoemulsification surgery has been fast-forwarded 4 times. As we can see in this video, the zonulisis was more than 180 degrees. So after making a sufficient rhexis opening, I inserted the iris retractor to support the anterior capsule and stabilize the bag during phacoemulsification. And then I inserted the CTR. After hydrodissection, I continued with phacoemulsification. Doing irrigation aspiration, especially in the site of zonulisis, was quite difficult. That is why there was some amount of cortical matter left behind. And because the bag was unstable, I left the patient aphakia. One day post-op, visual acuity was counting fingers 1 meter. Lens was aphakia. There was residual cortical matter inferiorly. IOP was 26 millimeter of mercury. Therefore, we gave antibiotics, steroids, eye drops, along with timolol eye drops, acetazolamide tablet, and oral steroid. Post-op 1 week and 1 month, vision was counting fingers 1 meter. By correction of +10 diopter sphere, the vision improved to 20/100. Lens was aphakia, and there was anterior capsular phimosis. IOP was 22 millimeter of mercury. Therefore, we still kept the timolol twice daily and acetazolamide once daily. Fundus photograph examination on the right eye showed a normal disc. The left eye disc had a cup-disc ratio of 0.8 with bipolar notch. OCT examination showed a superior and inferior RNFL thinning. So we planned the patient for a secondary IOL implantation along with pupilloplasty. As we can see, after the IOL implantation in the sulcus, I continued doing the pupilloplasty using a single pass 4-throw pupilloplasty technique. I personally felt that this technique is easy to be learned by beginner because this was my first pupilloplasty. So this is how we do it. This surgery is so much useful for the patient, not only for improving the vision, but also for eliminating the glare. So after doing the superior part of the iris, I continued with the inferior part. At the end of the surgery, the pupil had become smaller. First day post-op, visual acuity was 20/200 with the IOP of 16 millimeter of mercury. 1 month post-op, the visual acuity improved to 20/40 with the IOP of 15 millimeter of mercury. I did a YAG laser capsulotomy to clear up the visual axis, and I kept the patient on timolol 0.5% twice daily. 1 week after YAG laser capsulotomy, visual acuity improved to 20/25 false with the IOP spiked to 29 millimeter of mercury. Therefore, I added latanoprost eye drop once daily and acetazolamide once daily. Follow up 2 months, visual acuity was still stable 20/25, IOP was 14 millimeter of mercury. 3 months post-op, vision was still stable and IOP was 16 millimeter of mercury. So IOP is under control with 2 anti-glaucoma medication. What I want to highlight in this case is that ankylosing glaucoma, whether it's a primary or a secondary, needs immediate action. So given the patient anti-glaucoma medications, and the patient has to be taken for surgery immediately. This case is an example of a delayed case. So delaying means the patient may need more surgeries and also poor prognosis. In traumatic cases, informed consent that the patient may need more than 1 surgery is important. Like in this case, I informed the patient that after lens extraction or phacoemulsification, if implanting the IOL is not possible, then we will need another surgery to do a secondary IOL implantation along with pupilloplasty. And if the IOP is uncontrolled in the future, then we may need a glaucoma filtering surgery or a drainage device surgery. Thank you for your kind attention.
Thank you. Dr. Agus, any comment regarding this case?
Yeah, glaucoma caused by subluxation lens. Yeah, we have lost sonolacin more than less than is 120 degree, maybe better for the CTR. What is more, maybe better for capsule tension segment. This is good job for the nurse. It's very good.
Okay.
Thank you.
Thank you. Professor Pauhili, your thoughts?
Well, pupilloplasty is a very fiddly operation. So it takes a good surgeon to make their first one look good. And I think, you know, that's the feature of this case. Taking out lenses of eyes with subluxated lenses is tricky. It's very difficult, and even if you can do your best job, you can put that CTR in, and you can still end up with sufficient vitreous that comes around that tears the rest of the zonules. So I think it's a good result. The pupilloplasty result was good, and of course the consent is absolutely critical because although there was a secondary angle closure, there was obviously quite a severe force on that eye, and that force may well be enough to have caused a traumatic glaucoma on its own. So, you know, and even though that patient is now well controlled with medical therapy, you know, they need regular follow-up really forever, because their trabecular meshwork may give up from the trauma in years to come, and it would be a pity that such an excellent result would be undermined by a patient being lost to follow-up and coming back with uncontrolled pressure that needed glaucoma surgery.
That's true. Dr. Firna, any additional comments?
Regarding the IOL implantation in the sulcus, we have to be very careful putting the IOL in the sulcus for the patient with the subluxated lens. Then we know that the presenter said that the zonal lysis is actually more than 180 degree. So if we want to make it stabilize, actually maybe we could put like a ioneering CTR. So we could make a suture in this the ring, and it will make the capsular bag stabilize, and then we could put the IOL in the bag. So it depends on the possibility of, the affordability of the CTR ioneering. I think not every center has that. So we just follow up the patient. If we put the IOL in the sulcus, we know that sometimes we know there is a condition with like uveitic glaucoma hyphema syndrome. So be very careful in doing the observation for the patient in the future. But I think this is a very good job.
Thank you, Dr. Firna. Thank you, Dr. Nur Khairunnisa. Our next video presentation is by Dr. Ririn Nislawati, titled GDD Implantation in Secondary Open Glaucoma Post-Retinal Surgery.
Assalamualaikum warahmatullahi wabarakatuh. Well, my name is Ririn Nislawati, and I want to present a case presentation about glaucoma drainage device implantation in secondary open-angle glaucoma post-retinal surgery. The case is consulted from to glaucoma subdivision on November. From retinal subdivision is Mr. SN, 44 years old, consulted by vitreoretinal subdivision with blurred vision and pain on his right eye after surgery 2 weeks ago. There was no history of glaucoma, and there is a history of diabetes mellitus. The history of surgery on October, there is a right eye transplant vitrectomy, fluid eye change, endolaser, silicone oil 1,300 at hematogen retinal detachment, and 5 years ago already got the cataract extraction surgery. The medication from retina is Glaucoma every 12 hours, Timol, and KSR. From the anterior segment, we saw the visual acuity is 20/200 from the pinhole. The IOP is 40 millimeter mercury. This is the last eye patient on the right eye. The antechamber is Van Herrick tree with the cell +1, and the lens in both eye is IOL on position. From the gonioscopy, open on the right eye with the silicone oil emulsification on trabecular meshwork and irisophase in superior. The left eye closed with the anterior synechia from 1 to 2 o'clock and high pass on 2 o'clock. The nervous optic of the right eye, medium-sized disc pale with the vertical cup disc ratio 0.8 and excavating. The left eye no fundus reflex and because of the retinal detach. The Humphrey visual field 24 to low test reliability, and because of we see the fixation lows, we stand from 19, it means that more than 25%, but it seems like the visual field index is 60% with the mean deviation is -11 decibel. And the oscillity of the nerve fiber layer thinning on the superior and inferior quadrant. We diagnosed the patient with the right eye secondary open-angle glaucoma post-retinal surgery, status post-partial nephrectomy, FIA, EL, and silicone oil 1,300, left eye pseudophakia, and retinal ablation. The therapy is same with the retina. We increased the Glaucoma, become every 8 hours, and ask patient to come in the next 10 days. In the next 10 days, the IOP is still 24, and then we give the more Glaupen and increase the dose of Glauceta, and we advise to the vitreoretinal to do the silicone oil evacuation. They do the evacuation on December by vitreoretinal division. The next 10 days, it seems that the IOP is decreased, become 20, but with Timol and Glauceta 6 hours per day. We continue every month on December and on January. It seems that the IOP is stable with the medicamentosa, but the visual field is decreased, become 54%, and the increase defect of the main deviation. So we decide to do the glaucoma drainage device VGI with implantation with total external tube ligation to anterior hole tube ligation. On the first 3 days, the IOP is 44. So we give the maximum medical therapy. From February until May, the bleb still flat for 3 months. So and the IOP is control around 24 with the maximum medicamentosa. We were planning to do the flushing tube. On the day we decided to bring the patient to the OR for the flushing, the bleb is formed. So we decide to do the observation and give the maximal medicamentosa until June. Here we see that the bleb seem encapsulated, IOP 18 with the maximum medicamentosa, the NFL thinning seem progress. So we decide to do the right eye needling and injection 5-fluorouracil subconjunctiva. This is the progress. The IOP around 12 for 24. And the latest follow-ups is on June 25. It's 2 weeks after needling right eye. The IOP 25 with pipette and timol. So we edit AZOP. Here's the summary of the operation. So we have a 3 question. What is the cause of increasing IOP? Why did it take longer time to form the bleb? When do we decide to do the bleb needling? The IOP after surgical increase, whether it's transient or continuous, but for the vitrectomy and penetrating keratoplasty, it increased continuously. The exact cause is still unknown, but possible because of the inflammatory. The mechanism of IOP increase, the secondary glaucoma from the silicone oil procedure, is because of the migration of emulsified and non-emulsified oil into the angle, infiltration of trabecular and mesroc by oil droplets, and trabeculitis or inflammation. The indication for GDD is a glaucoma after vitrectomy surgery, and we know the complication on the involving valve is IOP fluctuation and hypertensive phase. The hypertension phase, it could be happen early or late. And some procedure we can give the anti-glaucoma medication or giving the digital massage. For the encapsulated bleb, we can see this patient get a decreasing height of bleb, fibrosis of the flap, vascularization, and increasing IOP. So we do the needling indication. We do the needling because the indication to solve the encapsulation, increasing the flow to the posterior and black bleb diffuse, which is the bleb needling success in 78% with additional anti-glaucoma medication. This is the reference. Thank you.
Thank you, Professor Paul Healy. Your thoughts regarding how to manage IOP high after the GDD implementation? What do you think?
One of the frustrating things about GDDs is that the pressure ends up where it ends up, and there's not a lot you can do about it. So sometimes we get wonderful results and pressures of 10 on no medical therapy. Other times the pressure stays stubbornly high. Certainly if the pressure is running higher than I think it ought, the first action is, of course, to make sure that the tube is actually functional. If it's stented, remove the stent, make sure that any ligatures are actually have actually dissolved or been broken. You can get fibrous tissue growing into the tube, in other words, into the mouth of the tube on top of the plate, and in that case, certainly doing a needling and a sweep can work. But the fundamental reason for most tubes why they run high pressures is the capsule's too thick and the hydraulic conductivity is too thick. And although the literature, which is really just a whole lot of case studies, doesn't show much of an effect for an anti-fibrotic, common sense tells us that the way to prevent fibrosis is with an anti-fibrotic. And certainly, personally, I went through phases in my career where, I used antimetabolites, and then all my colleagues told me there was no evidence of a benefit, so I stopped. And after about 12 months, I went back to using them because all my pressures ran higher. So I think, antifibrotics sometimes help control pressures in tubes. You don't know which ones it's going to help, but applying it that far back and making sure, of course, you use something like a Claisian clamp to apply the mitomycin to the tenons rather than to the sclera so far back in the eye, your risk of complications is minimal. That would be my only other suggestion. For this particular patient, you can, it's long and complicated. You can de-roof the bleb and apply mitomycin to the tenons and then do a needle sweep. In my experience, once they start to fail, they continue to fail. If this patient was in Sydney, I'd be considering perhaps a micropulse diode laser, looking first to see whether they had a good response to Diamox or acetazolamide. Because if they do, then diode can work well. However, of course, I have the same concern as all of you about a vision loss after circular photocoagulation.
Thank you, Professor. I think due to time, we have to move on. Our last video presentation is by Dr. Andrini Ariesta. Dr. Andrini cannot attend this session live due to COVID. We thank you, Dr. Andrini, for the video presentation and hope she'll get well soon. The title of the presentation is
Assalamualaikum warahmatullahi wabarakatuh. Good day to audience. I would like to say thank you for attending my presentation. In this meeting, I will be present my experience about management of neovascular glaucoma. A case report: a man 59 years old was sent to from vitreoretina. The patient is known to have uncontrolled type 2 diabetes mellitus since 2016. From retinal subdivision, the patient has been diagnosed with PDR plus DMA plus vitreous hemorrhage. From previous medication, we found that post-planar vitrectomy plus intravitreal anti-VEGF injection had been performed, as well as laser panretinal photocoagulation. In May 2019, the patient was consulted from vitreoretinal subdivision with visual acuity, red eye, hand movement, IUP 45 mm mercury to corneal edema. The patient was diagnosed with secondary glaucoma right eye. The patient was advised to undergo surgery but refused to do so. Maximal anti-glaucoma medication was prescribed with acetazolamide, kalium aspartate, and timolol. At 1 week follow-up, the IUP was 48 mm mercury. So the decision to perform filtering surgery plus anti-metabolite right eye was made. At the post-trabeculectomy follow-up, the visual IPT was finger counting, anterior chamber shallow. Hypema was found with 1 mm of head. IUP was 9 mm mercury. In the following week, visual acuity right eye was finger counting. Hypema is known. IUP was 16 mm mercury. At 1 month follow-up, visual acuity right eye was finger counting. IUP was 16 mm mercury. 5 months follow-up, visual acuity is still the same. Neovascularization was seen at the iris. IUP increased to 25 mm mercury at the left eye. The patient was given timolol maleate eye drop. 7 months follow-up, the patient complained that his left eye side was blurry and painful. From ophthalmologic examination, we found visual acuity left eye 0.1, corneal edema. IUP was 45 mm mercury. The medication given well: acetazolamide, kalium aspartate, and timolol eye drop. Trabeculectomy with antimetabolite plus anti-VEGF injection was then performed. In 1 month post-op, IUP right eye was 23 mm mercury, left eye was 16 mm mercury. Timolol was administered. The next follow-up, the IUP was 24 millimeter mercury. Follow up at 5 months for trabeculectomy right eye, the IOP was 26 millimeter mercury. October 2020, on 9-month follow-up, there was elevation in IOP. The patient complained about blurry vision and pain on the right eye. Visual acuity right eye was hand movement. Progressive iridis was found. IOP was 40 millimeter mercury. Medication was given and we planned glaucoma drainage device procedure. 1 day post glaucoma drainage device surgery, the IOP was 11 millimeter mercury. In 1 week post glaucoma drainage device procedure, visual acuity right eye was hand movement, the cornea was clear, implant was in good condition, IOP was 7 millimeter mercury. In 1 month post-op, there was no significant improvement. IOP was 11 millimeter mercury. There was an elevation in IOP in the left eye, and timolol maleat is given. On March, glaucoma drainage device was performed on the left eye. Visual acuity right eye still the same. Ocular left eye decreased to hand movement. The cornea was clear until chamber deep enough. IOP was a little bit high, 23 millimeter mercury. And at 1 week post of follow-up, the visual acuity right eye was still the same. Left eye 0.2, IOP right eye was 30 millimeter mercury, and left eye 60 millimeter mercury. Discussion: neovascular glaucoma is a secondary glaucoma that occurs because of posterior segment ischemia. Proliferative diabetic retinopathy was reported to be the leading cause of neovascular glaucoma. Management of neovascular glaucoma includes pan-retinal photocoagulation, combination anti-glaucoma drugs, surgical intervention, antivascular endothelial growth factor injection. In this case report document, a patient with rapidly progressive neovascular glaucoma as a result of PDR, diagnosed with diabetes mellitus since 2016, with history of past planar hysterectomy and panretinal photocoagulation performed on both eyes. The patient had anti-VEGF injection for 6 months in 2018. Blood glucose level affects diabetic retinopathy progression. During the course of the disease, the patient's blood glucose levels were not controlled. This caused progressivity of the disease even though the treatment for PDR has already been done. Thus, neovascular glaucoma occurred. After the trabeculectomy was performed, it was found ineffective. IOP kept increasing, so we decided to place a glaucoma implant. Take-home message: neovascular glaucoma can be affected by patient systemic condition. Neovascular glaucoma management can be done by treating the underlying disease with pars-plana hysterectomy, retinal photocoagulation, and anti-VEGF injection. Anti-glaucoma medication could be administered. If it doesn't work effectively, consider surgical option with glaucoma implant. Thank you.
Dr. Firna, any comments regarding the management of this case?
Thank you, Dr. Zeras. I guess for this case is neovascular glaucoma, and it unfortunately it is in both eyes. For the first treatment for the first eye, I guess it is a bit late to perform the GDD implantation. It should be like, we know that the trabeculectomy or filtration surgery in the neovascular glaucoma usually fail in a very early time. So I usually, if I found a neovascular glaucoma, especially this patient has a vitrectomy and also there are a lot of complication in the eye, I usually just do the GDD implantation. So that's why we could see during the follow-up from 2019 until then, the GDD was implanted on 2021, I think. Then the IOPs could be well controlled. So in this case, I guess if we have a neovascular glaucoma and then the patient has already been doing so many surgery, just go straight to the GDD implantation rather than the filtration surgery. I think this is the take-home message for us.
Thank you, Dr. Firna. Dr. Agus, any comments, additional comments?
Yeah, I think important for the neovascular glaucoma, define EUP control and follow up, look for the neovascularization develop, because it's sometimes like radiculectomy, BDD, maybe after several months, EOP good result to decrease, but long time EOP come elevated again. I think better for the look for the neovascularity, right? Treatment by anticoagulation or anti-PGF. Thank you.
Thank you. Quick comment, Prof. Healy.
I think this highlights the problem we have when we can't get rid of the vascular endothelial growth factor. If it continues to be produced, then often our more conservative treatments fail. So it highlights the importance of getting that VEGF under control, making sure that retina people do absolutely as much PRP as possible.
Okay, thank you. I think this concludes our session. I would like to thank all our speakers, panelists, Prof. Paul Healy, Dr. Firna, and Dr. Agus, and all the participants. We hope this has been a great knowledge sharing session and will be helpful for us in dealing with our patients.